Yes.
Good evening, madam.
Yes, good
Yes,
evening,
ma'am.
Dr.
Can you
Upma.
see me?
Welcome.
Can you see me? Yeah.
Yes, yes, we can
I
see you,
can hear
madam.
I
your
was
voice.
not. I was not aware.
You was not aware. They didn't call you?
No, no one called me.
Ma'am, I called, I left a message also and I had
Actually, I
WhatsApped
was.
also. If
Actually, I
it
was in
is,
Vietnam. I just came at night.
I left a message also. Probably
So
because
maybe.
it's from a non contact number, it would have gone missed also.
Anyway, she
Fine,
has come.
fine.
See her
Sorry
sincerity.
about.
We'll start.
Thank you for joining.
Okay, thank you, madam.
Thank you, ma'am, sir, for joining. Shall we start, madam?
Yes. Welcome, Upma.
Thank you, madam.
We'll meet day after tomorrow.
Yeah. I'm coming on. Actually, I'm 14 night.
Oh, 14th morning I am going.
I'm coming night because I have US Embassy interview for the visa, US visa.
Okay. Go and enjoy.
So
Start,
we shall
Panamina.
start.
Start.
Yes. So the Obstetric and Gynecological Society of Southern India, Fogsy Urogynae Committee cordially invites you to the webinar on Viewpoint, 8th of its kind, by News, standing for North, East, West, and South. The topic today is menopause and the menace of urogynec problems. To discuss this, we have a very important speaker from our own fraternity, Dr. Meera V.V. Raghavan ma'am, and we have chairpersons. Before we start, we like to welcome our president to give the welcome speech. So, Sampath Kumari ma'am,
Thank you, Dr. Meena.
professor and
Leave
HOD.
it.
Thank
See,
you,
I
ma'am.
welcome you. Thank you, Meena. See, this is the Urogynae program which is conducted by Dr. Meena and Dr. Meera every month. So this is eighth program, I think. We have one speaker and the discussion from the experts from East and West. Today we have the speaker of from South, our Meera Raghavan. We have the expert from West, Dr. Geeta. Welcome, Dr. Geeta. And from North, Dr. Bhupma. Welcome, Dr. Bhupma. And Basap is held up with emergency. He is from the East. So this program is in the YouTube. We have many people viewing this. So one will be speaking, the all others will be giving the expert. I welcome you all and I welcome all the delegates for this interesting program and I wish the success of this program. Thank you, Dr. Meena.
Madam. So we take great pleasure in inviting our chairpersons. So Dr. Geeta Balsarkar, madam. She is the professor and unit head, Nauroji Vadia Maternity Hospital and Seth GS Medical College, Mumbai. Honorary consultant, Tata Memorial Hospital, Mumbai. Editor Emeritus, Journal of Obstetrics and Gynecology of India. Editor-in-Chief, International Journal of Infertility and Fetal Medicine, Vice President of Mumbai Obstetrics and Gynecological Society 2025, Vice President-elect ISOPAP from West Zone 2026, President Association of Medical Women in India, Mumbai Branch 2021, President Menopause Society, Mumbai Branch 2021, Chairperson of Young Talent Committee, Foxy 2014 to 16, received the prestigious Hargobind Foundation for the Study of Fetal Medicine in 2008 at St. George Hospital, London. Next, we welcome you, ma'am.
Thank you.
Thank you, ma'am. Next, we have Dr. Upma Saxena, ma'am, Professor Consultant, Head of Unit, VMMC, Safdarjung Hospital, New Delhi, in charge of Fetal Medicine and Genetic Clinic. She has been the chairperson, Fetal Medicine and Genetic Subcommittee, AOGD, from 2025 to 2027. Over 3 decades of teaching experience in obstetrics and gynecology, FNB fetal medicine, 200 plus scientific papers published in national and international journals, 400 plus patients and 100 plus book chapters, editor for the Foxy focus on fibroids and EEBR placenta, invited keynote speaker and panelist at leading national and international conferences, actively involved in organizing CME workshop and academic events, lifetime member SFM Foxy, Nachi, IAGE, co-group member of Foxy Safehood Committee and publication reviewer of AJOG, BMC Pregnancy and Childbirth, BMJ Jogi, research principal investigator, co-principal investigator for ICMR and Ayush projects, won lot of awards and achievements. WHO Fellowship in Gynecological Oncology from IRC Lyon, France. Editor for the Foxy Focus on Fibroids and ER Placenta. Past Treasurer, AOGD 2020-21, Marchi 21 to 22. Fields of special interest in high-risk pregnancy, minimal invasive surgery. Welcome you, ma'am. Next.
Thank you.
We have Dr. Basab Mukherjee, sir, who's UA Foxy 2012, organized Endogyne 2015-17, 24, Boxcon 2018, ASCOG 23, Feto Vision 24, Wisdom 24, AICC RCOG 19 and 24. He's been Vice President Foxy 22 to 23, member FIGO Safe Abortion Committee 17 to 23, Chair IRC India East 24 to 27, President Bengal Obgyn Society, Secretary IAG Bengal Chapter. Awards and achievements: UA Foxy Kamini Rao Orator 2003, AO Fog Young Gynecologist Awardee 2009, DC Datta Best Publication 17, as Secretary Box for Foxy, National Awards, TRG member, Family Planning, MOH and Family Welfare, Government of India, Pride of Foxy 2021, Clinical Examiner for MRCOG Part 3. Over to the chairpersons to introduce our speaker. Welcome,
Can
ma'am.
Yeah.
Yes, ma'am.
So shall I introduce?
Okay, Dr. Upma, you introduce.
Okay, ma'am.
Yeah. So welcome Dr. Meera Raghavan. She is senior consultant urogynecologist and a robotic surgeon. She's a proctor and training Hugo Ras robotic platform. She's convener for TNFG FOG certificate course in Urogynae, board certified in lifestyle medicine physician, national board specialist committee member. She's treasurer SOVSL TN chapter, co-committee faculty Urogynae committee Foxy since 2015. Scientific Chair AICC RCOG to 2025, National Board Coordinator and Examiner, MRCOG Trainer and Examiner, and she's Director Scott Apollo Simulation Center Coordinator for Obstetric Skill, and she's winner of 32 gold medals in undergraduate curriculum and best ongoing PG student PGIMR Chandigarh. So welcome Dr. Meera. You're muted.
Meera, you're muted.
You're still muted, Dr. Meera.
Yeah, no, she
Unmuted.
Yeah. Now we can hear you.
Thank you, ma'am, and thanks for joining all of you. It's a great pleasure and honor to have you all here. May I now share my PPT?
So I think Dr. Meera will be covering both menopause and incontinence. Huh?
Yeah.
So two in one. Two in one.
Everything
So,
pretty much. I have introduction. I have covered GUSM as well, so everything. So we all know that menopause is a natural life stage which we all have to embrace and understand and be aware of. And we know that urinary incontinence is a common but kind of under discussed issue. And it's definitely higher prevalence among postmenopausal women with serious impact on the quality of life, often associated with social exclusion, embarrassment, and stigma. So the main purpose is to explore the effects and management and the causes of it as well. So what is urinary incontinence? It's an involuntary escape of urine, which is more prevalent in women, and it has various types in the form of stress, urge, or mixed incontinence. And why it is considered a menace? Because of the various reasons of the physical impact of patients with incontinence wear diapers can develop ammoniacal dermatitis, voluntary restrict water intake, can develop recurrent UTI, and have psychoaffective disorders associated with the depression as well. And it is important to detect early and not treat them just as UTI and offer relief so it doesn't become a chronic one where intervention needs to be done. The global prevalence of urinary incontinence suggests that 30 to 50% of our postmenopausal women are bound to develop urinary incontinence. I've also put down the evidence at the side from 2024 and its variation by age and region. Various factors influence prevalence, and the underreporting which happens due to the fact that women do not come forward. One, because they reconcile to the fact that that's how it is going to be as they age, or they are told that it is due to their diabetes or due to the UTI, and it is not treated as a separate entity, which is why we healthcare practitioners who deal with women should be creating such awareness platforms for empowering women with the knowledge. So, Indian studies on urinary incontinence also establish significant differences between rural and urban population. And they have noticed, especially in Western India, the cultural practices do affect reporting. Rural women do not come forward to report it because of the stigma associated with it, or because they are ashamed of revealing such a condition. It does have a serious impact on women working, and there are barriers to seek help. It's not just about awareness. They do not know whom to go to because they are inhibited to approach a male practitioner. At the same time, they do not know who exactly they need to approach, which is why Indian study and data are very much important for us to develop our own database. So the prevalence starts increasing round about the perimenopausal age group. Perimenopause is a time frame which can be around 3 to 5 years before the cessation of periods as such. And urinary symptoms do peak during premenopause. There is an increasing frequency of maturation along with leakage because of the fluctuating hormone level. These could be early warning signs and need early intervention as well. So dealing with the stress incontinence, it's leakage with physical activity or when coughing, sneezing, or laughing, or even sexual intercourse. These usually are the triggers which unmask the weakening of the pelvic floor, and definitely more prevalent in menopausal women. And we are going to look at the treatment options. Whereas urge incontinence is a sudden urge to urinate accompanied by either the presence or absence of leakage. So it can be a dry overactive bladder or a wet overactive bladder. When they notice that there is a significant impact on overactive bladder with relation to female sexual function as well as the general quality of life. So all urinary incontinence women do have a significant impact on their sexual life and the quality of life, and it is significantly linked to menopausal hormonal changes. Urge incontinence is a reflection of declining estrogen, and thereby the bladder becomes overactive, and further weakening of the pelvic floor muscles tends to worsen it. Mixed incontinence is a combination of the presence of both stress incontinence and overactive bladder. However, it can pose challenges in diagnosis, which is why we need to take a detailed history. A bladder diary is very relevant in these patients. A simple uroflow can determine how the patient is, and a post-void residue. Urodynamics is also indicated in patients with mixed incontinence because we need to treat the most bothersome symptom first. So we need to ask patient whether they have both urge incontinence and stress incontinence, and which is causing a much degree of bother, and that has to be treated first before we proceed on to interventional therapies. There are other types of urinary incontinence in the form of functional incontinence and overflow incontinence. These again are because of further cognitive decline, especially in our aging elderly women who stand beyond the age of menopause, what we now newly terminology, which is called geripause. Now they are presenting more with significant cognitive decline and can develop either functional incontinence or overflow incontinence. Overflow incontinence typically happens because of significant estrogen depletion that in turn causes atrophy of the vaginal tissue and thereby causes stenosis of the meatus of the urethra, leading on to retention of urine and overflow because of the same. Not only in postmenopausal women who are living into their 80s or 90s, but also in women with certain collagen vascular diseases or in patients with Sjogren's syndrome can develop meatal stenosis because of the tight tissue around the urethra due to urethral stenosis. and develop overflow incontinence. So patients with lower urinary tract symptoms of any age, especially associated with either SLE or collagen vascular disease or rheumatoid arthritis, need a thorough evaluation so we will be able to find the root cause for the urinary symptoms. So hormonal changes in menopause, as we have already elaborated, is significant estrogen decline, which in turn affects the urogenital tissue. There are both bladder and urethral changes. When I explain to the patient, it is both the storage as well as the conduit, which is giving out the passage of the urine. So patients will develop storage symptoms in the form of urgency and urge-related leak and repeated frequency, and voiding problems in the form of difficulty in emptying the bladder, or time taken to initiate the stream, or poor stream, or feeling of incomplete emptying of bladder. So pelvic floor weakening will cause stress incontinence, and role of other hormones, especially with further decline in testosterone, will lead on to lack of libido and poor sexual function as well. Definition of urogenital atrophy, basically symptomatology of dryness and irritation, which further increases the urgency and frequency. And they will have sexual dysfunction in the form of dyspareunia, which will also lead on to marital or sexual disharmony, and subsequently will be developing repeated urinary tract infection because of the lack of the vaginal defense due to the protective nature of estrogen. Pelvic floor weakness, menopause worsens it, but already there must be insult, which is the reason why they would have developed pelvic floor weakness. Repeated childbirth, multiparity, and aging themselves cause pelvic floor weakness. They can present with pelvic organ descent or leakage. And we have our prevention strategies like avoiding excessive weightlifting and concentrating on pelvic floor exercises much earlier before the onset of these sequelae. Is age a risk factor for incontinence? Yes, geriatric population, aging population is one of the prime reasons, and we have our studies from our Kanyakumari district itself, where it has shown that UI increases with age. It is basically because of the lack of the collagen basis of the tissue, which is why certain interventions like bulking agents are there to cause better coaptation of the urethral mucosa by supplementing the collagen in the urethral base. So the etiology is one of the reasons why certain interventions are done, and we need to tailor our intervention depending upon the age as well as the presenting symptom. Parity and childbirth, I've already elaborated. Vaginal versus cesarean delivery is a common bone of contention as to the causation or predisposition to urinary incontinence. Vaginal delivery, repeated vaginal deliveries with associated prolonged labor or instrumental delivery and big babies definitely predisposes to prolapse or pelvic floor weakness associated with stress incontinence or overflow or overactive bladder. However, cesarean delivery does not confer immunity towards development of incontinence or prolapse. The effect is lesser compared to vaginal delivery. However, just a patient having cesarean delivery does not nullify or negate one's risk of developing incontinence in the future. This is an important argument which has to be placed for women requesting cesarean section, saying that my mom had prolapse. Is it okay for me to undergo elective cesarean section? We have to be categorically telling them that cesarean section does not confer immunity against prolapse. Whereas early postpartum rehabilitation, maintaining optimal weight, is much more protective in nature for development of future incontinence or prolapse. Obesity is a definite modifiable risk factor because it's the impact of the weight on the pelvic floor. So there is a significant role of diet and exercise, which is fundamental in the management of most of the incontinence problem. There is a strong correlation between smoking and urinary incontinence. Smoking affects the vasculature of the bladder. Smoking causes predisposition to recurrent UTI. Smoking causes carcinoma in situ as well as carcinoma bladder. It is known to cause significant ischemia, leading on to worsening of bladder pain syndrome. And it also leads to significant thinning of the collagen tissue, further leading on to worsening of already existing stress incontinence. Apart from that, a smoker's lung with persistent cough is a definite cocktail to develop stress incontinence in the future. So that is the effect of tobacco on pelvic floor and bladder health. So it is imperative for us to deter all women using any form of tobacco in their life. And this needs a whole lot of awareness and community education. Comorbidities, definitely there is a correlation between UTI and urinary incontinence. The prima facie risk factors like age, menopause, estrogen decline, voluntary restriction of water, all predisposed to the combined presence of UTI and urinary incontinence. Symptoms overlap. Most of the urinary incontinence are unfortunately treated as UTI with antibiotics. UTI can worsen urinary incontinence. However, antibiotics will not cure urinary incontinence. This has to be made very clear to our women as well as practitioners. You might reduce the amount of urinary incontinence with treatment of a temporary UTI. However, the overactive bladder stress incontinence need ongoing management in their own merit to find a better symptom relief. Prolapse and incontinence also coexist. 40% of women with pelvic organ prolapse can present with incontinence. It is imperative that we determine the type of incontinence because overactive bladder needs medical management with lifestyle management, and correction of the prolapse to some extent can cause relief of overactive bladder symptoms such as urgency, urge leak, and frequency. However, if there is stress urinary incontinence, it is important that we find out and confirm the presence of stress incontinence and either offer them concurrent continence surgery while correction of the prolapse, or do the continence surgery as a staged procedure after 3 or 4 months, depending upon what the patient wants. So proper counseling is essential, and therefore it is mandatory that we do a thorough assessment and a urodynamics in a patient who presents with both prolapse and incontinence. And such is the importance of individualizing management strategies, and one size does not fit all. I'll have to make yet another important aspect here as a take-home message. Anterior colporrhaphy is a prolapse correction surgery. Anterior colporrhaphy will not treat symptoms of stress incontinence and should not be offered in patients with stress urinary incontinence. In fact, it can worsen the stress incontinence because by putting back the bladder in position, you are placing the bladder in line with the urethra, which will unmask a stress incontinence which had been masked because of the kinking of the urethra. So anterior colporrhaphy is a prolapse correction surgery and not a treatment for stress urinary incontinence. Socioeconomic factors, definitely overcrowding, manual lifting, unavailability of the access to their healthcare, their own cultural beliefs, and lack of proper reporting all contribute to the worsening of incontinence as well. So looking at an overall symptom overview, frequency and nocturia are very common with urgency and urge-associated leak, and they vary according to the type of incontinence as well. So the table at the side is again from our Indian population, which clearly shows the number of women who tend to have a combination of both urinary incontinence due to stress and urge, ranging up to 40%. The diagnosis is by history taking and the use of validated questionnaire. I have shown on the table on the right side a sample size varying anywhere between 200 to 530, which has shown the prevalence to be ranging from 25% to nearly 46%, like what we saw in the literature. And the key outcomes noted that there is a higher prevalence in perimenopausal women, and stress urinary incontinence was more common. This could again be the fact that more of Indian women have multiparity and poor pelvic floor rehabilitation following vaginal delivery, therefore predisposing them to higher incidence of stress incontinence. So when do we seek help? When do we teach our women to seek help? When there are red flags like frequent leaks and pain associated, impact severe on the quality of life, when they do not know whom to go to, they need this education. And it's also important for us to emphasize the early intervention where lifestyle changes as well as pelvic floor rehabilitation could reverse an incontinence process. Whereas when you proceed on to a moderate or a severe form of incontinence, you will need intervention therapy. So we have already noted what are all the physical impact which could be seen with this. They are prone for UTI as well as hygiene product related dermatitis. Ammoniacal dermatitis can be very severe and can cause excoriation, ulceration, and they constantly smell of urine and thereby leading on to further discomfort and pain. These are all the psychological impacts which can happen, especially loss of confidence. No wonder the slogan goes that continence is confidence, and they are prone for more sleep disturbance. In fact, in our cohort of patients, we did a study on the prevalence of sleep disturbance in both premenopausal and postmenopausal women who had suffered from incontinence and presented at the Indian Menopause Society. It was clearly shown that the premenopausal women had severe sleep disturbance related to incontinence as opposed to the postmenopausal women, possibly because the postmenopausal women had reconciled to the fact that they will be incontinent or were wearing diapers already. So there was a significant impact on the sleep as well as the quality of life. We've already gone through this, so I won't waste my time on that. Does it have a sexual health impact? Definitely has a sexual health impact because of the vaginal dryness and discomfort, which is an important factor which causes both sexual health dysfunction as well as incontinence. They have reduced sexual desire, probably because of discomfort or embarrassment. They can be associated with pain during intercourse, and this incontinence can have avoidance technique for them to avoid intimacy with the partner. It can lead on to relationship strain as well as reduced satisfaction. It takes some time for them to even realize that the sexual dysfunction is existing, and sexual dysfunction is a consequence of the incontinence in the first place. So they have physical limitations, emotional distress, social and sexual impact, also economic burden. Imagine the cost of adult diapers, and there are women who have significant nocturia and have to have change of 3 diapers every night. It significantly causes an economic burden and a further reduction in quality of life. Henceforth, dealing with this is about holistic care. So we now know there are various reasons why women do not seek help, and we have to address this not only by treating them, but also teaching them prevention. So weight management is paramount in the management of incontinence or overall pelvic floor health in the first place. So women should be advised and recommended that at least 5% weight loss could improve their incontinence as well as dysfunction of the bladder by about 70%. Dietary changes, especially in their fluid intake habits, to avoid caffeinated drinks. No caffeinated drink should be taken beyond 4 p.m. because that increases the diuresis in the night and can cause significant nocturia as well. Regular exercise, especially concentrating on the core as well as the pelvic floor, is paramount for maintaining good bladder and pelvic floor health. I've already emphasized strong enough about tobacco cessation, importance of pelvic floor exercises. Do not just tell them Kegel exercises. Use your examination during vaginal assessment. Keep the two fingers, assess the pelvic floor tone, assess the pelvic floor muscle contraction and the strength of the contraction. Teach them pelvic floor exercises. If you ask them to download a link, they will not be able to understand. A quick tip for everybody, the way I tell my patients is, I tell them every time they go to the loo, after they have emptied the bladder, they wait there and contract the pelvic floor muscle 10 times. So a woman would visit the washroom about 7 times in a day, and every time 10 times pelvic floor contraction after the act of micturition makes it about 70. It's equivalent to doing 70 biceps curls. The muscle gets really stronger. Same will happen to the pelvic floor. And it's about advising adequate hydration with the correct fluid and avoiding any fizzy drinks or caffeinated drinks. So Kegel's exercises are important, and use this at every opportunity, even sensitizing adolescent girls, pregnant women, postnatal women, women who come for routine checkup, just like we discussed opportunistic cervical screening. Like that, we need to sensitize our women about the importance of pelvic floor exercises, how to perform them correctly, and their importance in role of postpartum care. Behavioral therapy, bladder training techniques. This is a common issue which happens because of parental anxiety. So childhood learned habits of improper bladder training can lead on to voiding dysfunction in the future. So women need to be advised that they need to empty bladder by the clock every 3 hours. So on a jocular vein, I tell the women they should be able to see a Shah Rukh Khan movie without getting up for a loo break, which means it's about 3 hours. So scheduled voiding and avoid any bladder irritants as well. And this is very, very crucial in maintaining good bladder voiding habits, especially in overactive bladder. Pharmacological options are plenty. We have the antimuscarinics in the form of oxybutynin, tolterodine, as well as sulfasalazine. We are lucky to have the introduction of fesoterodine. It's given as a 4 milligram or 8 milligram. It does not cross the blood-brain barrier, and it's much more selective and causes good symptom relief as far as the antimuscarinic group is there. We now thankfully have beta-3 agonists in the form of mirabegron and bibegron, which act on the storage capacity of the bladder. They do not affect the motor function. So these patients are not at risk of urinary retention, which makes them superior to the antimuscarinic options which are available. For women who do not do well, either because they are not happy with these effects or they develop side effects such as dry mouth and constipation, will probably move on to botulinum toxin, which can be injected intravesically, which offers good symptomatic relief for a period of about a year or year and a half, and can be repeated upon patient request, depending upon the worsening of the symptoms of incontinence. Is topical estrogen important? Definitely important in terms of offering benefit for urogenital atrophy in the form of cream. We do have pessaries in the West, but they are not available here. They are the first line treatment for atrophic vaginitis and genitourinary symptom of menopause. We're talking here only about the topical estrogen. Systemic HRT is not indicated in patients with genitourinary syndrome or urinary incontinence. In fact, they can worsen the urinary incontinence. Pessaries and devices. There are Hodge pessaries with urethral support, which offer support to the paraurethral area, but these have to be done alongside pelvic floor rehabilitation and are not really available for patient usage and can be only imported. So that is a kind of a limitation in the use of pessary for stress incontinence. Multiple surgical procedures are available. However, the gold standard for the management of stress urinary incontinence still remains the mid-urethral sling in the form of a retropubic TVT or a transobturated tape, which can be either inside out or outside in. Birch-Corpus suspension used to be the gold standard. However, the time taken to operate, the number of complications, or the benefit offered from the mid-urethral sling surpassed the superiority of Birch-Corpus suspension in the management of stress urinary incontinence. With the bad press, which was available for the meshes, which was pretty much like a knee-jerk reflex due to conspiracy between the legal firms and the mesh surgeons, autologous facial sling did do a comeback in the form of pubovaginal sling or fascia lata used as a sling, which we call sling on strings for the management of stress urinary incontinence. The steps are the same like mid-urethral sling. However, the mesh or the polypropylene tape is replaced by either a strip of rectus sheath or a strip of fascia lata, which then offers support to the mid-urethral area. The important point here is use the appropriate tape, which should be a macroporous polypropylene tape. Anything different from that is more prone for macrophage attraction, infection, inflammation, and thereby causing mesh-related complication. So it is actually wrong to blame the device when actually people have cut corners for cost-cutting purposes or other reasons using different substitutes than the recommended sling in the first place, which led on to the disrepute for the mid-urethral slings. However, in Europe and the rest of the world, mid-urethral sling still continue to be the choice of surgery for the management of stress urinary incontinence. Are there any medications available for stress urinary incontinence? Yes, the SSRIs in the form of duloxetine can be used in the management. However, it is temporary and can cause some drowsiness and cognitive decline in certain patients, especially if they are elderly. It is usually given in the dosage of 20 to 30 milligrams per day in a temporary fashion about 3 months. However, it can be given in patients where surgery cannot be an option. Recently, I had a patient with bronchogenic carcinoma with severe stress urinary incontinence at 75 years of age. I am not going to do any sling surgery for her, and this would be a welcome option to give her certain degree of quality of life while she is managing her bronchogenic carcinoma-related problems. Are there any updated trends and what is the evidence behind that? This is what we talk about standard Kegels. Biofeedback as an adjunct to the pelvic floor muscle retraining has offered a better success rate than just Kegels. So biofeedback can be reserved for patients who are not able to understand pelvic floor exercises, or for even better, do not even understand about the pelvic floor, for them to have a visual impact and guidance of what is the pelvic floor contraction all about. Laser therapy for urinary incontinence, is it effective? It is only effective in grade 1 to 2 stress urinary incontinence. Only if the patients with very mild incontinence, it has to be offered. These can be YAG lasers or carbon dioxide lasers. These are not the same as vaginal rejuvenation or vaginal tightening. YAG lasers are not the treatment of choice with severe incontinence. They are not the treatment of choice with prolapse-associated incontinence. Grade 1 to 2, where patients are not doing proper Kegels exercises, who need symptom improvement, which is temporary, this can be offered. But unfortunately, lasers also have to be done in at least 3 sittings over a 45-day period, and that itself is quite cost significant for the patient. Radiofrequency ablation works on the same principles as the laser and is offered in parallel with the a laser for the management of stress incontinence. Again, I have to mention this is only temporary and it has to be done repeatedly for management of early stress incontinence. What about these chairs which have come into vogue? These chairs have the usage of causing nearly 11,000 contractions of the eagle. People who do strength training do know that repeated contraction causes muscle fatigue. So I'm not very sure as how the chair would be beneficial for somebody doing 11,000 Kegel in one sitting. These are a session duration of nearly half an hour, typically 6 sessions over 3 weeks. They are shown to improve bladder control and reduce urinary incontinence episodes, especially in patients with disturbing overactive bladder, in fact, if they are younger in age. There are now talk about artificial intelligence and digital health in urinary incontinence. The AI in diagnostics as well as therapeutics are multifold. We now have smartphone which provides you the bladder diary. There is a bladder app with a water app, and also smart pants which have sensors which detect urinary incontinence episode, especially in the elderly, and can treat them with bladder retraining procedures as well. This is just the evidence put together with regards to the retropubic sling as well as the transobturator sling. Please note that the follow-up outcomes are available for now nearly 18 years, and the success rate is either 85% or 79%. So the long-term efficacy both for TVT and TOT is comparable in the order of 94% and 81% respectively. TOT had fewer complications overall, but most of the mesh-related complications happened in the TOT group rather than the TVT group. So TVT is more successful. TVT has immediate complication rate, which is higher than TOT. However, TOT has long-term complication rate, which is higher. So these are the mesh controversies and the alternatives, which I've already mentioned to you about. And moving on to the bulking agents, moderate improvement in the stress urinary incontinence typically lasts 4 to 5 years. It offers 65% success rate in patients with definitely intrinsic sphincter deficiency. And however, a third of the patients will require repeat hyaluronic acid-based bulking agent, either in the form of Bulkamid or macroplastic in the urethra. It is done through a cystourethroskop. We have already gone through the medical management of OAB, and these are the various clinical trials in OAB which offer the evidence to what we are doing in terms of medical management. And there are trials now available for Botox as well. A further advancement in the management of overactive bladder or refractory incontinence is in the form of sacral neuromodulation. It definitely offers more than 60% success rate. I shouldn't be not saying 60%. 60% of the patients can have significant cure rate with sacral neuromodulation in terms of refractory overactive bladder. However, these batteries have to be changed once in 15 years. Thankfully, we have the long-term battery now available in India. It is done under sedation in a prone position with the C-arm guidance, and patient can have the permanent leads in about 4 to 6 weeks time, and they carry on with the programming of the battery with the smartphone application itself. It's not very cumbersome. This is how we place the sacral neuromodulation pacemaker, which I fancy call it bladder pacemaker for the patients. This is evidence regarding the importance of Botox. Urinary retention can happen in 5 to 10%, and risk of urinary tract infection can happen to 10 to 15%. I'm going to, for want of time, I'm going to stop that video and move on to importance of creating awareness by various models, as well as empowering patients with our talks, as well as our articles, and importance of social media in creating awareness about incontinence. So empowering women with knowledge and practical skills is a crucial element of ongoing successful incontinence care. I think I will end my presentation there, and I'm happy to take questions or have experts give their comments as well.
Dr. Basab is there?
Thank you, Dr. Meera. It was really very comprehensive. You have covered all aspects of SUI and other urinary problems. You also touched upon the genitourinary syndrome of menopause. So, which is very, very common. In fact, according to me, each and every menopausal woman will be having this to some extent. Some may be having it more and some less, but it will be definitely there. And so we have to spread this awareness more and more. But one thing that really troubles me, like when we travel, the availability of toilets that is there when we travel is actually quite bad. I don't know how it's in South India, but in Maharashtra, at least like when we travel to Pune, Nashik, Nagpur, on the road, it's really a bad scenario. And many of my colleagues and friends, they have something like PD or some, a lot of other, this is available for, being able to pee safely. So these are other things also which we have to touch upon, because especially these women won't be able to sit down in an Indian toilet if they are perimenopausal age group, and non-availability of Western toilet can cause a lot of problems to these people.
That's a very valid point, ma'am. I have to make two important take-home messages here. The myth about public toilets being the cause for UTI has to be bunked. Public toilets are not a source of urinary tract infection, because urinary tract infection is not contagious. It is the overgrowth of abnormal bacteria within our gut. However, hygiene matters, and therefore people refrain from using public toilets. How we need to encourage them to void at regular intervals so they do not develop a concentration of bladder bacteria and thereby develop UTI. That has to be encouraged. And the
Dr. Meera, even I want to congratulate. It was a very lucid presentation, but I have few points I want to ask regarding. You said for incontinence just doing anterior corporaphy. What is your viewpoint about Kelly's repair? Because when
Kelly's repair is not a recommended procedure for stress incontinence, because the type of suture we use, the tissue we use, is only in the mucosa. That is not going to support anything within the mid-urethral plane where the incontinence happens. Though people claim that Kelly suture they have done in the past and that's what they have been taught and they have
actually when
had
we are
no
doing
problem. They have not
if
had
we are doing
problem.
anterior corporaphy, sometimes if there is a history of incontinence, then
it
we
will
go
not
ahead.
correct. The patient will come back with incontinence at some point in their down the lane of 3 to 6 months.
One query about the mesh. Earlier we was doing lot of TVTs and TOTs, so now they are not available. So in India,
are available.
They are available.
We do
in our
TOTs
hospital we are
and
not
TOTs.
getting. So it's available now.
Oh,
It's
very much
available.
available. Very much available.
So you're again doing TOTs and TVTs.
We've always been TVTs and TOTs. Only the UK and the US did reflex jump on this and stop doing it. They are actually regretting it because they have nothing else to offer to patient, and they started offering lesser options which are not that effective and which is not great. And their training cohort did not have the requisite training or expertise in birth as well. And not all patients are fit for birth. Say if I'm doing a vaginal procedure, how am I going to do just the incontinence procedure by birth?
So you have to open the abdomen just for, you can do, if you're doing some other surgery just for incontinence, doing birches is not an answer.
Yeah.
And it's a major kind
from
of
the
surgery.
Last Ayuga, I think TVTs will make a comeback in the West as well.
Actually, we are getting a local make tape available in Mumbai. We don't even have to spend so much. And I use a Shirodkar's, the sling needle, that we use. And with minimum expenses and with a, almost 350-400 rupees, good tape we are getting. And I am doing routinely, but only once there was tape erosion. and the patient presented with bleeding, and whatever was a tape I pulled out, but her SUI was gone.
The
So most important thing in the
do
tape is that
cystoscopy.
it should not be very tight, otherwise it will lead to retention. So it is a double-edged sword. So you have to be careful about that.
Yeah.
You
And
should
do a
put the artery and
cystoscopy.
then suggest it. You should do on cystoscopy. That's a must for TBT because you may go inside the bladder. So you have to do a cystoscopy after that.
Yeah.
And regarding the drugs, this antimuscarinic agents, they are quite effective. But in elderly patients, you will have to be
very careful.
We have to be careful, and we have to counsel that they have to take it for minimum 3 to 6 months. That's my preference.
Absolutely agreed.
I think the most important thing as an obstetrician, I'm not a urogynecologist. We always, a general gynecologist, we ask them to lose weight, to maintain a bladder diary, and to do bladder drilling. What you said, time urination.
3 hours.
That is very important. But you said every 3 hours.
Sugar in control. Blood sugar should be in control.
And blood sugar. UTI and blood sugar. I always check first any patient who comes with the UTI. That is very important basics. Because you have to rule out urinary tract infection and uncontrolled sugars. I don't know what I have done. Yeah. And weight loss. Weight loss helps a lot, and your Kegel exercises. If you, as you said rightly, the once she goes for urination, she does it 10 times. That is very important. But when they pass urine, they know which muscles they are using. Otherwise, they are very confused.
Yeah, very confused.
So biofeedback, I think in India, we should have biofeedback cones, which they have to keep in vagina. And this, I think that's very easy for them to understand which muscle to use.
Yeah. They are
keep the cone inside.
Actually, the correct time to start Kegel's exercises is in the postpartum period. So we should start teaching them Kegel's exercises right from the postpartum period so that they don't develop it later on at menopause. Like most of the patients, they come to us directly with a complaint like after 45 years, and that is when we deal with them. But the correct time to deal with it is in the immediate postpartum period.
And say much earlier, because nowadays with the younger generation, more filming marathon and pelvic floor, so it doesn't have a debilitating effect on the pelvic floor. So sensitize them to pelvic exercises at that stage. Otherwise, it can become too late.
But many organizations, they are against the urodynamic studies just for plain incontinence, for urge or your stress. Only.
No, there is nothing called, as I told you in my studies, which are Indian data, very, very rare to find pure stress urinary incontinence. So and with the litigation as well as the litigation surrounding tapes and the availability of resources and insurance, it is a legal requirement for us to document the type of incontinence rather than go on with the clinical.
Okay, so for all patients,
isolated pure incontinence comes few.
Definitely,
it is important for us
to label her as GSI, you have to rule out retrusal activity. Then,
exactly.
So that, and history taking, I think we should teach our youngsters. History taking is very important. How to differentiate between.
The most important aspect to dissuade is bladder bowel NAD has to stop.
And for the postgraduates, I want to say, even if you have planned an abdominal hysterectomy for a big uterus, please do per speculum examination to see if she has a cystoscopy. Otherwise, post hysterectomy, they will come back with SUI. So that's one thing which many of postgraduates nowadays they miss. I asked them, did you do a PS? Did you look at the cervix? They said, madam, she's for abdominal hysterectomy. You know, this is their thing. Patient is uncomfortable, patient is not comfortable, but no, we have to evaluate. Cystocele is something which we can evaluate only vaginally, not by sonography, not by anything else. And a per speculum examination has to be done the previous day of your surgery, whatever, whether it is a lap surgery, lap hysterectomy, whether it is a abdominal hysterectomy, you have to evaluate the cystocele and whether she needs a cystocele repair. Because many times we find that patient does a hysterectomy for a large uterus, they go home and then they come back with a fresh complaint of SUI because it has not been tackled from below.
So any women who comes with incontinence, most important history. Then you have to rule out UTI. Then you have to rule out blood sugar, whether uncontrolled diabetes is not there, and prolapse. I think these are the 4 things which has to be done for every basic gynecologist. And if they find, then to make the diagnosis more clear, if they're all normal, then definitely this patient should be referred to a urogynecologist for their expertise on this. So I think making them, the women aware is more. I think we should ask ourselves, do you have any problem of leak? That should be part of our history as a senior gynecologist.
Absolutely.
Because many women, when you talk to them, then they come out. And that's true. The urban women, they are more because they are doing multitasking and they are professionals. So for them, it's more worrisome. A woman who is a homemaker, she doesn't mind going to toilet every time. But women who is working professional, definitely it bothers her more. So that's why they complain more compared to a rural woman.
And all patients with prolapse definitely need all these questions, because pelvic floor has 4 domains. One is prolapse, one is urinary incontinence, bowel function, sexual dysfunction. Unfortunately, the last 3 are always missed, especially the sexual dysfunction and bowel. Take up anything related to pelvic floor, all the 4 have to be addressed discreetly, otherwise we are about to miss out on one.
And I think estrogen therapy, local therapy, is very easily available. And any women complaining, I think it should be the first line because it helps. It definitely helps. And definitely systemic therapy is definitely no for incontinence. Local therapy and Avalon cream is available permanently. So they can put it. And it's very important that they should not use it. How much time you ask them to use it? Because usually people say usually
this local
daily for 1
estrogen
week
therapy,
and then taper and stop.
No need to stop. Local estrogen therapy should be used at least 2 to 3 a week and minimum of 3 to 6 months. But you have to explain to the patient it can be used long term. It does not get absorbed. It is not a risk factor for breast cancer. It does not cause uterine cancer just by using it. However, if the patient is on local estrogen therapy and develops any postmenopausal bleeding, investigate postmenopausal bleeding like you would do for anybody else and not just attribute it to the local estrogen therapy. Then you're bound to miss out on a course.
Studies are there with local estrogen therapy, which has been used for up to 1 year.
Yes.
Therefore, we can definitely use for 1 year without a break.
Easily,
up to 1 year without a break. And then taper it off or whatever way
you can stop it also. But
stop it
is
also.
important.
Abruptly stop it.
And ask them to apply everywhere where there is irritation rather than just insert vaginally.
And most important thing, what I counsel is should be used before intercourse. So sometimes they think it's like a jelly for dry vagina. So that should be, I think, part of our counsel.
Or if some patients are uncomfortable with directly applying on the vagina, I can even tell them to apply on the thigh, the inner aspect of the thigh. No, whatever closest to the vagina they are comfortable with applying, even that works. With that also the vaginal epithelium and the uroepithelium improves.
And regarding the Ms. Meera background, what is your viewpoint? So in case of women who are elderly and multiple having medical problems, so what do you do?
is a safer medication in women who are elderly and with multiple problems because the anticholinergic burden is not increased. However, if they are hypertensive and have a systolic blood pressure of more than 160, it can have cardiovascular effects. So we should exercise caution in the usage of Mirabegron. Now, Vibegron is still not available, but will be very soon
Mirabegron
introduced.
is available.
Mirabegron is. Vibegron, which is a newer one, will be introduced very soon. It's cardiovascular safe and does not have that deleterious effect on the hypertensive aspect.
So what is the part?
To anticholinergic, this is better.
What is the part of your counseling? Usually I tell them it takes minimum 3 months to be effective.
Yes.
So
bladder medication
have to
take minimum 2 weeks to be effective, maximum benefit in 3 months. So you should be able to continue it for 3 to 6 months. Absolutely.
That is very important because the patient, they want immediate effect. So they should be counseled that minimum it will take 2 weeks and they have to take 3 months for maximal benefit. That's true.
And they will stop it on their own, dissuade them from stopping it on their own, because the incontinence will come back. For that, I tell the analogy, you wear specs and you're able to see clearly. Would you take off the specs? No. So continue the medications.
So they can continue long term also.
Yes.
Okay.
But under
So how long?
supervision. No,
Under
everything
supervision.
3 to 6 months, but under supervision.
Okay.
Depending on, we can taper it and stop it, but they should be willing to go back on it if they have symptoms of incontinence coming back.
So regarding your bladder drilling or the time voiding, what I tell my patients is that they should do it, first of all, more frequently, every half hourly, then increase it to hourly, but they should not wet themselves in between, and they have to find the time for themselves, which
No,
there is
every
a low
half hourly
leak.
will
No, they have to
functionally
increase.
reduce the capacity to the bladder. What you need to do ideally is 3 hours is the target, but you cannot do it straight away. What
If
we
you
need
leak
to
in
do
between,
is look at the bladder diary that will have a functional capacity. So if it's say 150, then start with 1 hour duration at the outset. Make it 1 hour, ask them to go every hour, empty the bladder. The next week, make it 1.5 hours. And over time, by the
try to
time you
increase.
reach a month or so, make it 3 hours in a comfortable manner. They should not leak. They should be able to get up from the place where they are, reach the loo, get down their pants, and then do. Otherwise, they can potentially have an accident.
You have to start with a shorter time and slowly you have to increase it.
Yeah, that's true. That's true.
Basically, you have to make them comfortable so that they don't leak in between.
Yeah. The primary aim of treatment of incontinence in elderly people is to prevent falls. That has to be made very clear to them as well as the carer. So whatever it takes to prevent falls has to be done with regards to treatment of incontinence.
So caffeine intake and smoking, you said,
Definitely
should avoid after the afternoon, your caffeine intake.
Yes.
That's very important.
Very, very important.
There are small things, I think, which can make their life comfortable.
Very true.
Regarding the surgeries, if you do your TVTs and TOTs, you must have done it now. They have been in the market for pretty long time. So they are effective for how long? Because major thing was
these are all now evidence-based for nearly 17 to 20 years.
Okay, that's a long
So
time.
they are very, very, very effective.
Okay. Earlier, the puberethral slings, the lasting was not much. They never used to last long. So now these tapes, they've been proven they last for 18 to 20.
See, it is very important for us to understand these tapes were done anatomically, but the pelvic floor is a dynamic one. So if they put on weight, if their epithelium in the vagina becomes very thinned out, these problems can come back. So it is important to continue lifestyle, continue pelvic floor exercises, continue estrogenization of the vaginal epithelium so that the incontinence doesn't surface back.
I think.
So thank you, Dr. Meera. It was really very interesting.
Thank
you. We had a nice interaction. Thank you.
Thank you. Thanks for
And
the
we
lovely
also learned a lot
inputs.
from you, Dr. Meera.
Thanks for the lovely inputs. Thank you.
It was eye-opener.
Thank you.
Thank you.
Thank you, Upma ma'am, and thank you, Geeta ma'am. Thank you, Dr. Meera Raghavan ma'am, for the excellent discussion on menopause and urinary incontinence. It was eye-opener for our delegates. Thank you so much, madam.
Thank you.
Thank you, Sri Events, for being there as a platform. And thank you for dear delegates who have joined in large numbers. Thank you.
Thanks a lot.
And thanks for inviting us.
Thank you. Thank you. Sorry about the voice message. It didn't probably reach you.
It was mine.